I'd now like to introduce our next speaker, Dr. Ann Child again, because we had trouble with our neurosurgeon who was willing to give the talk, but unfortunately is now abroad giving this same lecture in Israel. So he sent it to me and said, you know, do your best. So the next topic is Dural Ectasia. And this has been composed with the help of Professor Papadopoulos, the academic neurosurgery unit at St. George's University of London. Now, he didn't know anything about Marfan syndrome when I was on staff there, so I kept sending him my patients. And he's the only person in England now who will operate for Marfan syndrome dural ectasia. So there's an example. If you insist, they learn. So what is dural ectasia? It's a widening of the dura, which is the envelope around the spine, and it holds the lubricating fluid for the spine and the brain. Unfortunately, when we stand up, the fluid tends to drain down into the lumbosacral area and causes quite a bit of pressure. But just as the aorta can expand under pressure, so the envelope around the spine can expand under pressure. And when it does, it occurs quite often in Marfan syndrome. It occurs in 40% of children, but usually asymptomatic, and 65% of adults with Marfan syndrome. Only a very few actually complain about it. And the most common presentations are low back pain and headache. And the headache is an unusual one. It's new. It gets worse when you stand up. It disappears when you lie down. And it doesn't respond to painkillers very well at all. So what do we do about it? 90% of patients get better with medication. That's the good news. And that includes bed rest, hydration, because you have to keep pressure up within the cerebral spinal fluid, caffeine, and then that doesn't work. It may be because there's a leak in the dura, and it may develop a little tear, usually in the anterior wall. In that case, then you need a surgeon. And this is a treatment that Marios uses. It's called blood patching. So a little bit of blood's taken from the arm, and then it's injected under local anesthetic into the back, and bed rest is required then for a week afterward. But that has a 90% cure rate. The most common symptoms I mentioned were low back pain or headache. But because the pressure can affect the nerves leaving the spine, it can also produce weakness, numbness above and below the affected area, and occasional pain in the rectal, genital, and abdominal area. A CT scan can be used if the patient has a pacemaker, but images are more accurate with magnetic resonance imaging. And on the right, we see a beautiful picture of the spine in cross-section. The diagnosis is made based on measurements. And on the left picture, you can see that the vertebrae are being measured with the white lines drawn across them. On the right picture, you can see that the fluid containing area, the dura, are being measured with the black lines drawn across. And the radiologist makes a ratio of those two. And obviously, if the lines on the right are bigger because of dural expansion, then he can make a diagnosis of dural ectasia. Occasionally, you get a little cyst or a meningocele, a bursting forward through the vertebrae into the abdomen. And if that shows up on the picture, then you have to empty that cyst by going through the anterior abdominal wall and using a sharp needle to drain the cyst. The blood patching is used for headache due to leak. Open surgery is avoided wherever possible because you may make it worse if you go in and try and actually stitch the leak together. Patients with these symptoms need to be referred to a neurosurgeon like Mr. Papadopoulos for investigations. In the UK, there are very few who will actually operate. Mr. Papadopoulos doesn't know of any others except himself. So probably best to try and treat it conservatively. But again, you need the neurosurgeon to make the diagnosis. The fourth bullet point is interesting. If you do an MRI scan of the brain with the patient standing up, it shows a sign called sinking brain, which means that because the brain has lost its fluid or is losing its fluid, then the brain slides down a little bit towards the spine. And this pulls on the pain-sensitive structures in the skull, like the meninges. And it's felt that that's really where the headache's coming from. So, bed rest, lots of fluids, pain medicine, high salt diet to keep the fluid in the cerebrospinal fluid. With severe cases, I'll show you in the next picture an epidural venous blood patching. So venous blood's taken from the arm and under local anesthetic. You can see the patch in the left diagram. There's a little hole in the green dura, and that's where the cerebrospinal fluid is leaking from. So the needle is aimed directly at that area, and the blood from the arm is injected, and this causes pressure around the spinal cord, which helps to seal the leak. It heals in 7 days, but the patient goes home with instructions not to BLT, bend, lift, or twist for 7 days. Activity is restricted for a further 3 months, and the patient's advised to avoid strenuous exertion or exercise. Walking's fine, and taking stairs is highly recommended. And the success rate, I'm glad to say, is 70 to 90%. The references in the literature are few and far between, but I want to draw your attention to the second one, Loeys-Dietz, Dural Ectasia, a likely cause of inadequate spinal anesthesia in 2 parturients with Marfan syndrome. So during delivery, women are often offered an epidural anesthetic. However, if the anesthetist isn't aware that the patient has dural ectasia, then the injected anesthetic gets diluted up and down the spine because there's more fluid at the base, and it doesn't have its expected effect because it's been diluted. So it's just as well to remember that during delivery. We have a leaflet on this topic, and the reference to it online on our web is on the left under information leaflets. So if you think you may have this problem, please do look on the website, and you can download one of our pamphlets to take along to your doctor. Thank you. Any questions? Has anybody in the audience had dural ectasia? And how were they treated? And what was the outcome? You see how rare it is.
Although patients say, supporters say that of everything they suffer in Marfan syndrome, it is the most painful, but that the doctors are convinced. They've diagnosed themselves with dural ectasia, but doctors feel that their GP said, though you're conflating dural ectasia with just normal wear and tear lower back pain, how can you distinguish the difference? And the supporters feel undermined by this because they feel that they know it is dural ectasia, but they're not being believed.
Well, then they need to be referred for an MRI because that tells you the truth. So I think they just have to insist that they need a further investigation. If it's back pain, then they'll find problems in the back. If it's dural ectasia, they'll find from the measurements that the dural canal is actually larger than it should be, and they can take it further then.
Kate has written that her son has been found to have it mildly. He's 12. Whilst Amanda thinks she may have it, she has no pain, but when she was in labour for the first time, the epidural didn't work until they topped it up twice, at which point she couldn't move her legs. And Sonia thinks her daughter possibly has it. She certainly has had CSF leaks that resolve spontaneously.
Interesting. Is Nitha still with us? Dr. Nakvi, is she still listening? Because
Hi.
Hi, Nitha. You were saying you had a child and you thought they might have this. Did you find a specialist who would see the child?
Well, I did refer just generically to Queen Square, and they've had an MRI locally as far as I'm aware, but I don't think they've seen anybody yet.
No. Okay.
As soon as I find somebody, I'll let everyone know.
Please do, especially with Marius going off around the world lecturing. He's not always available. That would be a big help.
I attended the Marfan Foundation conference in Paris, as you know, and there were, of the 20 or so patients who attended, 5 suffered from dural ectasia.
Really?
Yeah. And it was a question that was they asked the question of the musculoskeletal doctor, who said you would need a neurosurgeon to answer it.
Yes. Well, it does develop with time. That's why there are 40% of children affected and 65% of adults. And since patients are living much longer, I mean, 30 years of research has added 30 years of life to the expectancy in Marfan syndrome. So the average life expectancy is well up in the normal range. I make it about 68 years, but certainly I have patients in their 80s. So I imagine the longer you live, the greater the chance of developing it if it's due to pressure. So we may be seeing more of it as our population ages.
I think Lizzie'd like to ask a question. Lizzie.
Yeah, I think I have it, but I've never had it diagnosed, but it happens very sporadically. So I get really bad headaches and I have to lie down, which it does resolve, but it takes quite a long time to resolve, like a day. But the painkillers don't work, and it's a very different headache to a normal headache. But I have a pacemaker, so I can't have an MRI, but I could obviously have a CT. But yeah, I just haven't had it diagnosed. I just tend to manage it myself by lying down. But it is the most painful. It is very painful.
Yes, I'm sorry to hear that.
Yeah, no, but yeah, I just haven't had it diagnosed. But yeah, I'm sure it probably is that. Yeah.
I mean, there are other causes of headache in Marfan syndrome. Migraines are more frequent. I'm not sure why. I think because the vessel wall is weaker, and so it tends to go into spasm more easily with an insult, you know, an allergy or stress. Then we also have sinusitis, but that usually causes a headache in the frontal region or the face.
Yeah.
Where does your headache appear?
It's at the base of my neck, just at the back of my head. Yeah. But I have vomiting with it as well. I get quite bad vomiting with it. So, and I get quite a lot of pressure low down, like you said. So it sounds like it is dural ectasia, but yeah, it's quite. I don't know if the vomiting is just with the pain, because it's quite severe. It's very severe pain. I'm not sure, but usually it does resolve. It takes about 12 hours to go.
Mm-hmm.
Yeah, but it doesn't happen very often. It's probably like once a month. Luckily, it's not that often. So
good.
Yeah.
Well, you can have vomiting with migraine.
Yeah.
Have you tried the medicines for migraine like Migralev or Imigran?
No, I haven't actually. No.
Might be worth a try.
Yeah. No, that might be worth a try. Thank you.
If it doesn't work, we won't be surprised.
Yeah.
But if it doesn't work, then I would ask to see a neurosurgeon.
Okay. All right, thank you.
They can't all operate, but they can certainly make a diagnosis for
Yeah.
you. And you're quite right, an MRI is safe. If you've got a pacemaker, they may have to turn your pacemaker to MRI mode.
Right.
You'll need to have your MRI in a center where they also have cardiology technicians.
Yeah.
And then you go and see them first, and then you have the MRI, and then you go back and they put it back onto your normal rhythm.
Oh, okay. Yeah.
Let us know how you get on.
Okay, thank you. Thanks.
Jolly good. Well, if that's all the questions, I think we should move on.
Kate asked if there is anything we can do to reduce the chance of it developing, because the geneticist believes that Dural Ectasia may be the cause of her son's headaches, although the orthopedic surgeon has said to ignore it completely.
Prevent it developing. The only thing I can think of is to stay slim, but then most patients with Marfan syndrome are slim anyway. Obviously, if you have more pressure in the abdomen, if you're overweight, or if you do a lot of sport, weight-bearing sport, you know, like running marathons, that sort of thing, it might not help. Frankly, I can't think of anything. What about you, Nitha? Do you have any suggestions for a child with headache that might be dural ectasia, what they can do to try and prevent it?
It's definitely very difficult, and when the children have headaches, it's always difficult to know whether it's because they've become too hypotensive, their blood pressure's fallen too much on the medication they're having, because we're obviously many of them are on either a beta blocker or losartan or irbesartan. So I normally suggest aiming for at least 2.5 liters of fluid a day. I mean, just what you've said. And although it's a bit counterintuitive because they're on antihypertensive, I do sometimes say try and increase your dietary salt. So I know that doesn't particularly make sense, but it's difficult. And sometimes, and I apologize if I'm repeating what you said, the beta blocker chosen could be propranolol, because we usually give as a beta blocker in adults bisoprolol and in a child atenolol, but propranolol is another beta blocker. It's 3 times a day, but it is actually a treatment for headache. So then it's kind of trying to deal with 2 things in this, so that the beta blocker is working in the way we want to lower the blood pressure, try and help reduce aortic root dilatation, but also might help with headaches. There is an adult form which is once a day, a slow release. The ones we usually use in children is 3 times a day. So I haven't got anything brilliant to suggest. And I did notice what you said about caffeine, and children love having Coke. Not great for the teeth. But if they're having fizzy drinks, we just generally suggest using a straw to try and protect the teeth. Okay, I hope that's useful.
Excellent, very useful. Thank you. Also, I'm remembering one lad who felt hungry and dizzy at school, and he was very slim and he didn't have much appetite. So he chose to try and skip breakfast. And we found that he needed frequent snacks during the day to keep his blood sugar up. Now, Marfan syndrome patients don't usually have a lot of fat, so they don't store energy the way perhaps other children do. And he really was very thin. So I started him on a series of, we found him a little locker at school. And when he was hungry, he used to go to the locker and have a snack. And it cured the problem. You know, something simple like a banana, like the Wimbledon tennis players use. You can eat it quickly, it's quite tidy. The teachers can't complain, and then back into class. So that's just another way of.
Yeah, I mean, I often find, Dr. Child, that a lot of the children don't have breakfast. They tell me they feel sick in the morning, and often they just say they're just too busy. It tends to be the teenagers. They've got to, maybe they're catching up on their homework, they're rushing because maybe they've slept late, because they've been on their phone, which is all normal teenage behavior, totally normal. And then as they don't have breakfast, then they start feeling unwell at school. So what I recommend is there's a lot of these protein bars around that loads of the children who are into fitness and trying to build up their muscles are having anyway. So I recommend those. And I also recommend the breakfast drinks. My favorite that I find people like is an Australian brand that you can get in all the supermarkets called Up and Go. And it's a milkshake type, strawberry, chocolate and vanilla, but it has contents in it that are very sustained release and give energy over a number of hours. And these are just little tips to try and see if they might help.
Thank you very much. Very practical advice. That's just what we need. Thank you.